This is Andy Alsbaugh from Duke University School of Medicine. In this lecture, I will discuss Pneumocystis pneumonia as an example of a lower respiratory tract infection in highly immunocompromised patients. Although there has been a confusing recent history about where to place this unusual organism within our pathogen map, Pneumocystis species are now known to be part of the fungal kingdom, although they are biologically quite distinct from the other free-living fungi. As learning objectives, we will identify patient features that predispose to opportunistic infections with Pneumocystis species. We will also discuss the clinical manifestations of these infections, and lastly, we will talk about ways to diagnose and treat these potentially fatal infections. I would first like to discuss a patient whom I met several years ago, a 22-year-old man who came to a local emergency room with 2 weeks of worsening shortness of breath. Although he had no known medical conditions, he was quite thin and chronically ill appearing, and he was also in respiratory distress, with an increased respiratory rate and increased work of breathing. He did not have any classic signs of pneumonia such as fevers or focal lung findings on exam. However, his oxygen saturation was quite low, and he had extensive oral candidiasis or thrush. His chest x-ray shown here demonstrated diffuse and very fine infiltrates. Together, the overall clinical findings, including oral thrush, alerted the emergency room physicians that the patient likely had a very compromised immune system, and subsequent testing confirmed that he had advanced AIDS with a low CD4 count. An induced sputum sample was examined using a methenamine silver stain, as demonstrated on the right-hand panel of this slide, revealing numerous cyst forms of the organism Pneumocystis. Let's explore the interaction between severely immunocompromised states, especially HIV infection, and the development of pneumonia due to Pneumocystis species. Prior to widespread HIV infection, Pneumocystis pneumonia was a very rare disease, occurring only in very severely immunosuppressed patients, such as children with leukemia. However, in the early 1980s, clusters of cases of Pneumocystis pneumonia were some of the first indications of a new immune disorder. This publication from the U.S. Centers for Disease Control described 5 cases of Pneumocystis pneumonia in the Los Angeles area, a very unusual occurrence. These patients had other opportunistic infections as well, including cytomegalovirus and oral candidiasis. Even before HIV was known to be the causative agent of the underlying condition, Pneumocystis pneumonia and other at-risk patients was also described, such as those who had received multiple blood product transfusions. In addition to Pneumocystis pneumonia, the patients were noted to have depletion of T helper or CD4 lymphocytes, later recognized as a hallmark of AIDS. Therefore, Pneumocystis and HIV infections are closely linked both clinically and historically. To reinforce this concept, let's look at a graphical representation of HIV disease progression. After the initial infection, the patient's CD4 cell count, demonstrated by the blue line, will gradually decrease over time, a marker of immune dysfunction. Additionally, after a typical period of clinical dormancy, during which the patient may be asymptomatic, untreated patients with HIV infection eventually experience a rise in their HIV viral loads, as demonstrated with the black line, as their bodies are no longer able to control viral replication. Now, during the later stages of HIV/AIDS, these patients become susceptible to many infectious agents, such as Pneumocystis, non-tuberculous mycobacteria, Cryptococcus, and cytomegalovirus. Pneumocystis as a microorganism was first recognized by a very famous clinical microbiologist, Dr. Carlos Chagas. He was especially interested in protozoan infections, and he observed what he thought was a new trypanosome, which he named Pneumocystis. For many years, this microbe was considered to be a protist, and much of its naming or nomenclature reflects protozoal naming conventions. It is now known to be a fungus rather than a protist, and its genome clearly reflects fungal genes and lineage. However, unlike many human fungal pathogens, Pneumocystis species cannot be cultured outside of the human body. All experimentation requires that it be grown and passaged in animals. However, it's also important to know that each mammalian host has its own unique Pneumocystis species. Therefore, mouse Pneumocystis is not the same species as human or cat Pneumocystis. And infection seems to occur almost at the first breath of life. Mouse pups become colonized with Pneumocystis within the first few minutes of delivery. And this is almost certainly the case with humans as well. Therefore, this may be a case of universal colonization with a commensal microorganism that is completely species-specific. Now, why this occurs and whether there is some advantage to the host is currently unknown. However, you must also know the correct species name for human Pneumocystis. Historically, it was called Pneumocystis carinii, and many clinicians will still refer to it by this name. However, the organism was renamed Pneumocystis jirovecii several years ago, and this is the way that it will be written in the medical literature and the way that I will refer to it for the remainder of the talk. Pneumocystis jirovecii lives in the host in several morphological forms, two of which are listed here. First, there is the trophozoite form, a very small form with reddish nuclei inside of host cells, as demonstrated in the upper panel. Note the protozoal-like name, trophozoite. The most recognizable form is the larger cyst, as seen in the bottom panel of the slide, that has the appearance of crushed ping-pong balls when stained with a silver-based stain. As we consider the microanatomy of this infection, the histological features will inform us about how the disease manifests. Here I'm showing you an H&E stained section of lung with Pneumocystis infection. Note that the alveolar spaces are really not spaces, but are filled with pink amorphous material. Where is gas exchange going to occur in this picture? When this process is occurring diffusely throughout the lungs, this is likely the reason that patients with Pneumocystis present with such profound hypoxemia. In fact, the symptoms common in this infection are nonspecific: dyspnea, cough, rapid breathing, and they reflect the profoundly reduced oxygen levels resulting from poor gas exchange in the alveoli. Lastly, the lung injury present in this infection can sometimes be indirectly measured by an elevated lactate dehydrogenase blood test. As noted in our case patient, the chest X-ray in Pneumocystis pneumonia will often reveal diffuse linear infiltrates consistent with the interstitial pattern of pneumonia we saw by histopathology. More prominent infiltrates emanating outward from the hilum can also give what is called a bat's wing appearance to the infiltrates in the lungs. Other types of lung radiographic changes are quite unusual in Pneumocystis pneumonia. Once we consider this infection, how do we make the right diagnosis? First, you must consider the correct patient features leading to this infection. It is almost never encountered in patients with intact immune systems. However, it must be considered in patients with late-stage HIV infection. In fact, AIDS patients with CD4 counts less than 200 have a risk of Pneumocystis pneumonia of 18% per year. Other patients at risk for Pneumocystis pneumonia include transplant patients, especially those on high doses of corticosteroids. In fact, if a patient has experienced Pneumocystis disease before, and if he or she is not being given appropriate preventive therapy, this patient will have a 5% rate of developing recurrent infection every month. Now, Pneumocystis pneumonia must be considered among the many things in the differential diagnosis of pneumonias in immunocompromised patients, but a high degree of suspicion will lead the clinician to the right diagnosis. Therefore, in this right patient group, the diagnosis is ultimately made by identifying Pneumocystis jirovecii at the site of infection. For example, respiratory samples are often checked by PCR for Pneumocystis DNA. Also, deep respiratory specimens can be analyzed for cysts or trophozoites, as demonstrated in these images. Once diagnosed, there are several treatment options, although each one has potentially serious toxicities. Perhaps the best therapy is high-dose trimethoprim sulfamethoxazole. Patients usually require several days of antimicrobial therapy before clinical improvement occurs. Other potential therapies include pentamidine and atovaquone, both of which are often used for true protozoal infections. Interestingly, the addition of corticosteroids in patients with low oxygen levels has been demonstrated to improve patient outcomes, perhaps by inhibiting excessive inflammation as the microbes are being killed. This is an interesting concept of using immunosuppressive therapy to inhibit excessive inflammation in patients who already have established immune system defects. It is important to consider prophylactic or preventive therapy for this infection. In many cases, we know that our patients are at a high risk of developing PCP, such as our patients with AIDS or those having recently received a solid organ transplant. Now, these patients should receive prophylactic therapy with agents such as low-dose trimethoprim sulfamethoxazole or inhaled pentamidine. This is an especially important consideration in patients who have actually experienced pneumocystis pneumonia before, since they are at a very high risk of disease recurrence, and this is referred to as secondary prophylaxis. In summary, let's review some of the most important aspects of pneumocystis as an opportunistic pathogen by returning to our teaching case. This patient came to medical attention with respiratory symptoms related to his profoundly low blood oxygen levels, but there was nothing unique about his presentation to suggest pneumocystis pneumonia. It was by their attention and astuteness that his ER physicians identified his immunocompromised state. Although he knew that something was wrong and that he was at risk for HIV infection, the patient was in a state of denial until a diagnosis was made. Pneumocystis jirovecii cannot be grown in culture, and therefore we needed to use other means to identify this organism in the infected tissue. In his case, we saw the cyst form present in deep respiratory specimens. Had this case occurred today, we might have used PCR to help make the diagnosis. Once the diagnosis was made, this patient was treated with high-dose trimethoprim sulfamethoxazole for this infection, as well as supplemental oxygen and corticosteroids since he was profoundly hypoxemic. He made a very slow recovery, and we were eventually able to use prophylactic antibiotics to prevent recurrence of this devastating infection. With treatment of his underlying HIV disease, this patient is now doing quite well, and his pneumocystis pneumonia is a distant memory.